cara. Que situação.
Depois você fala de mim, olha, tem um muito pior.
Porra, Roberto,
São,
tu pessoal
são os ares de
fantástico.
Curitiba me transformando, entendeu?
Porra, que isso,
Aqui a gente
cara?
fala que é água, deve ser água de Curitiba.
Meu Deus do céu. Ok, começou a gravar? Ok, boa
Beleza.
noite a todos.
Não, peraí, deixa eu só... Ah, tá. Acho que tá gravando aqui.
Boa noite a
Yes.
todos. Sei que queria agradecer a presença de todos vocês. Deixa eu ver que tem muitos aqui da América Latina. Não estou vendo nenhum aqui que talvez fosse em inglês. Talvez fique mais confortável para a Roberta falar em inglês, ou meu em português, eu não sei qual é o melhor para ela, já que ela teve essa formação em ambos os países. A Roberta foi nossa residente aqui. Eu digo que foi a melhor residente que nós tivemos, porque além de ser extremamente dedicada e estudiosa, ela sempre foi firme, mas sem nunca perder a ternura, né? Isso fez dela diferente dos demais. Quando ela foi para os Estados Unidos, em Boston, tá? Mostrou um trabalho fantástico e retornando para São Paulo. Hoje ela trabalha no Hospital Santa Marcelina, né? No grupo de neuro-oncologia pediátrica. Tem um trabalho fantástico desenvolvendo naquele hospital. Roberta, muito obrigado. E agora é mãe nova, né? Ou nova mãe? Mãe nova. Parabéns e ficamos muito contentes de ter você conosco aqui novamente. Robertinha, fica à vontade. Teu microfone está desligado. Tá.
Aí,
Agora
agora
sim.
está entendendo? Então, antes de tudo, doutor, obrigada pela introdução. Sou eternamente grata, tudo que eu aprendi, todo o caminho traçado, ainda tem muito o que traçar ainda, é muito espelhado no trabalho do senhor, só tenho que agradecer. Obrigada mesmo. E obrigada pelo convite. O senhor prefere que faça em inglês, doutor? O que o senhor prefere? Peraí, tá mudo, doutor.
Acho que pode ser em português.
Tá bom.
Eu vi um Mohamed Ramadan aqui. Eu acho que ele só vai entender em inglês, hein?
Então vamos em inglês, então.
Tá bom? Pode ser.
Ok?
O Guilherme vai compartilhar a tela.
Compartilhando ali, ó. Tá aparecendo ali?
Tá.
Tá. Beleza. Putz, ok.
Ok, go ahead.
Okay. So first of all, I would like to take the opportunity to give a talk. And what we're going to be talking about is some of the work that we've been doing at Santa Marcelina Hospital. And we start to do a molecular study on diffuse midline gliomas recently. So we're going to just do an introduction. And go ahead, please. So the brain tumors in pediatric is the solid tumors, the most common in children. Brain tumors is considered the second most common neoplasia. First one is leukemia. And it's estimated about 6 cases for each 100,000 between the ages of 0 and 19 years old, which is approximately 5,000 new cases a year in the US. Go ahead. Go ahead, please. This was a recent work published in Neuro-Oncology, which shows that, go ahead once again, the most common location of pediatric tumors is in the pituitary, which is in the craniopharyngeal duct. Second, we have the posterior fossa tumors. And third, go ahead. We have the brainstem tumors. Another slide, go ahead. So the gliomas make up approximately 41% of all the brain tumors in the pediatric patients, in which 60% of them are high-grade gliomas, and they are located in the brainstem. And that's why what is so interesting about this is because it's such a really no-touch location, and still is most of the common location for the gliomas in the pediatric population. Go ahead. So what are the risk factors known about it? So we have the radiation exposure that is well known for risk factor in pediatric. Identify predisposition syndromes, approximately 10% of the cases in which germline or somatic mutations may result in the same patients only brain tumors or only malformations, or even both of them in the same patients for the germline and somatic mutations occurring in the pediatric patient. Go ahead. The brainstem tumors, just an introduction, they can be located in three main portions between the diencephalon and the cervicomedullary junctions. And it accounts for approximately 20% of the primary brain neoplasms in children. Go ahead. So this is just a brief talk of some of the locations that we seen. So the mesencephalic location, the most common are tectogliomas, which are located in the tectal plate of the mesencephalon. And it accounts for 20% of the mesencephalic lesions. Most are indolent tumors, and we usually often treat the hydrocephalus with ETV and just do a follow-up of the tectogliomas. Go ahead. And then we have the medullary lesions. Also, they're often low-grade lesions. Between children are more often committed with these lesions between the ages of 6 and 8. 84% are considered astrocytoma, gangliomas, and oligoastrocytomas. And less than 20% are actually high-grade lesions. And it will depend what kind of lesion that we are treating, but if it is an anaplastic, there is a multimodal treatment with radiations associated to treat these patients. Go ahead. So recently, now we're going to be talking about the brains, the pontine and the diffuse type of the midline gliomas. So the 5th edition of the 2021 World Health Organization for the pathology, we have a pediatric type diffuse high-grade glioma. For the first time, we have a pediatric type and an adult type. So here we're just going to be talking about the pediatric type diffuse high-grade gliomas. They're usually classified in 3 locations. The midline gliomas, which is really the midline, including thalamus. We have the hemispheric gliomas, and we have the H3 IDH Y-type gliomas. So the midline gliomas, which is the most, what is interesting here for us, it's H3 K27 altered in 90% of the cases. Usually is associated with TP53 mutation, ACVR1 mutation, and PDGFRA mutations, which are very poor prognosis with less than 1 year, despite all the treatment implemented. Go ahead. So the pontine lesions, now we know it is, after the 5th revision, we now know it's not only pontine lesions, but it's a diffuse midline glioma. Most of them are H3 K27 altered. Those are somatic histonic mutations usually. These are high-grade lesions, accounts for approximately 80% of the pediatric brainstem tumors, and despite of all therapy that we have today, it's a dismal survival, less than 1 year of survival. Go ahead. So this one was a very interesting case that we actually discussed this case before. I don't have the video here, but we discussed this case with the radiologist, and I actually thought it was a extra lesion, but we tried to do a surgery, and we removed all the exophytic component, and then it came out. Go ahead. It came out to be a diffuse midline glioma H3 K27 altered with KI 67-40%, P53 positive, which is really related to a high-grade lesion. And it wasn't, what we did was we actually removed the exophytic component. And we only noted that after the MRI that we did after a month, that we noticed there was a contrast enhancement on the pons on that far right MRI, extra MRI. That's the post-operative control that it didn't show in the first MRI. So this was really a surprise, because what we did was a removal of the exophytic component. Go ahead. So the diffuse intrinsic pontine glioma, which is now called the diffuse midline lesion, somatic mutations in H3 K27 is approximately 90% of the IPG. And what we notice is a lysine to methionine substitute in the histone. And why is this important? This is important because all the lesions located in the diffuse midline lesions, there is a mutation in the histone protein. And this should be, in the future, a target therapy for this lesion. And despite of what the pathology shows, even if the pathology shows is a low-grade lesion, if there is a mutation in the histone, it is considered a high-grade lesion. Go ahead. So what are the diagnosis? Clinical manifestations with the progressive clinical manifestations, usually less than 3 months of manifestations. Those are kids that usually were playing, and now there is a progressive gait impairment, and cranial nerve palsies, headache. And then we do an MRI, and in most of the cases we find a diffuse pontine lesion, which embraces the basilar artery, as we can see in the first MRI flare with there is little there is a hyper signal in the pons, and then in the T2 we do have a hyper intensity in the pons. It's usually all diffused enlargement of the pons, and it's very characteristic of the IPG. And then we do a contrast enhancement. There is little contrast enhancement in the lesion, which is a really classic DIPG lesion. Go ahead. And the treatment, current treatment, there is still radiotherapy, chemotherapy in some cases that the kid is enrolled in clinical studies. Other options, again, in those cases enrolled in clinical studies, we have target therapy according to molecular studies. We have intratumoral direct infusions, some of the cases related. And now we are still developing immunotherapy to treat those patients. But besides of all the treatment implemented, we still have a dismal prognosis for this type of tumor. Go ahead. So then we started to do biopsies. There is also, we know that there is a risk of the biopsy, but now it's safer than it could ever be in prior days. We have some studies showing that how safe it is and how accurate the diagnosis can be during the proper biopsy. So we have this study with the IPG biology and treatment study in the USA, in which there were 50 patients with a diagnosis accuracy around 96%, no postoperative hemorrhage, in one case of hemiparesis, 0 mortality. We have also a French study that shows also how safe it is to do a DIPG biopsy. Approximately 130 patients, 5 cases with minor neurological deficit, and no mortality. Go ahead. This is just to show that it can be safe, it can be done, and it might change the prognosis of some patients. We have the INFORM study in Germany, in which were 21 patients enrolled, around 12 centers, with diagnostic accuracy 100%. One case developed hydrocephalus, and one neurological deficit. No mortality was reported. And there's also a meta-analysis which englobed 18 studies, approximately over 700 pediatric patients were studied, with diagnostic accuracy almost 96%, 6% of morbidity, and less than 1% of mortality. This is just to show that it can be done, it can, and it's safe to be done, and it can actually change prognosis of the patients under study. Go ahead. So what is the treatment strategy today for DIPG? Go ahead. What we know about it? We know that the midline glioma either is on thalamus or in the pontine. Those are composed with OPC stem cell-like, which is oligodendrocyte precursor cells. And what we know that when these cells are located more in the thalamus, those are midline locations, those are more mature cells. And this occurs in older children, in adolescents, and even adults. And the OPC cells located around the pontine regions, which are more commonly in children, those are more immature cells. And so that's the importance to study that. So maybe if we have a target therapy with the histone component of these lesions, we might find the cure for these patients, because it's a location that we can't do much besides doing biopsy. Go ahead. So we have some of the studies, and it's important to know that today there's around the world, there's several places studying this, but the two most important places that are developing strategies to treat those tumors, one is the Children's National with Dr. Roger Parker, and the second one is the Hospital for Sick Children, Toronto, with Dr. Vijay. Those are the most important pediatric neuro-oncologists that they're ahead of finding drug delivery therapy methods to reach out these locations to treat diffuse midline gliomas. So we have the blood-brain barrier treatment challenge. And now to overcome this, one of the strategy that is developed is we using high intensity focused ultrasound with microbubbles. With this, we can induce inflammatory response, it optimizes local regional drug delivery, and reduced systemic toxicity. Go ahead. So what we have, and then we introduced the magnetic resonance with the focused ultrasound. It's a minimally invasive procedure with lack of ionizing radiation. Again, this is all under study, but it has shown some promise in the results of getting the drug into the place that it needs to be treated. So there was this study with doxorubicin in rats, which showed after using magnetic resonance focused ultrasound that there was a high concentration of drug in the brainstem of the rats with doxorubicin, and it shows a promise in the treatment in the future using resonance guided focused ultrasound. And there is this phase 1, phase 2 with Dr. Roger Parker at the Children's National, that they're using low intensity focused ultrasound in 5-ALA for treatment DIPG. And what it does is a sonodynamic therapy that activates protoporphyrin, and this has a photodynamic effect that induce apoptosis in the tumor cells. And this is using, they're doing this study for DIPG. So there are a lot of things going on, and that's because it's a really hard place to get the drug into, and there is no surgical miracle that we can do much around the brainstem. Go ahead. And then came out this PNOC trial. The PNOC trial is a multi-center molecular profile trial which individualized treatment according to molecular studies. And it was a multi-center, and one of the leaders of this trial is Dr. Sabina Miller. She's one of the head of this trial that is conducting. So there were a total of 28 patients, ages between 3 and 25. And what they observed were 9 genetic mutations that were frequent in the DIPG H3K27 altered. Go ahead. So overall survival in those patients, approximately 13 months, with progression-free survival, approximately 8 months. Go ahead. So this trial was really important because it studied some molecular base of the DIPG, and it showed that when there was a TP53 wild type, it has a much worse prognosis if compared with TP53 mutated. And why this is important? This is important because it will tell me how much radiation I'm going to give to this child. If it is a really bad prognosis, how much is worth to give a high dose of radiation and affect, again, we're talking about pediatric patients here, how much radiation we give if the prognosis is already really bad with TP53 wild type, and then I got to think about quality of life of this kid. So prognosis bad, TP53 is wild type. Maybe I can give less radiation and give more quality of life for this kid that already has a dismal prognosis. So that's why this is important to know the molecular subtype, so it can actually help us how to treat this kid. Go ahead. And the PNOC trial also noted with the P10 wild type and P10 mutated, it also showed the same thing. The wild type showed worse prognosis compared to the P10 mutation. Go ahead. So the most important message from this trial was to find out that the TP53 mutation was associated with worse overall survival, with genome instability, and also radiation resistance. So based on this PNOC trial, go ahead, we started to do biopsy, diffuse midline glioma biopsy at Santa Marcelina. Our hospital is a public and private hospital. The neuro-oncology chief is Dr. Sidney Appleman, and he's really ahead of us, thinking about molecular studies and how we can do better. And we do have our lab at the Santa Marcelina, and we have all the equipment that we need, particularly for the pediatric patients. We have all the equipment that we need to do a safe biopsy in these kids and do molecular studies in our institution. And we can even, if there is a response to a different drug, a specific drug, most of the cases we can get these kids to be treated. So right now is a 2-year experience. We started in 2022. The only reason there is none this year is because I had a baby this year. She was born in January, so we still don't have. Hopefully I'll be going back soon, but it's a 2-year experience. So far we had 8 patients, 7 cases with DIPG, 1 case with thalamic lesion. 5 female, 3 males, median age around less than 7-year-old. In 5 cases, we did a frameless stereotactic biopsy using Brain Lab Vario Guide. 1 case was a conventional stereotactic biopsy. That was the thalamic lesion. And 2 cases was open biopsy. These 2 cases, one was the first case that we did. We didn't have the Vario Guide, so we did an open biopsy with the exophytic portion of the tumor. The pontine was a diffuse midline, a diffuse intrinsic pontine glioma, but there was a exophytic component. That was this portion that we did a biopsy, an open biopsy. And the second case was that other case that I showed you previously, in which we thought it was actually an extra lesion, but then it came out to be a diffuse pontine, a diffuse midline glioma. Go ahead. So in our experience, we have morbidity. We have 1 case with morbidity, which was this picture, the MRI that we shown. That was the kid that we did an open biopsy. Actually, I tried to resect the tumor, but it was the exophytic portion of the glioma tumor. The kid, before surgery, the kid was intubated. She had a respiratory arrest, lower cranial nerves palsy before surgery. So after surgery, there was a worsening of the cranial nerves deficit. Today, she's going to school. She does have a facial paresis, but she's eating, she's talking, she's going to school. She does have a left hemiparesis, but she's functional. We didn't have any mortality. I know it's a really is a small case study. We only have a few patients, but so far we have no mortality and just 1 morbidity with this case with the open biopsy. Follow-up, we have an overall survival of approximately 6 months and 5 deaths so far. Go ahead. Yeah, this is the diffuse midline glioma that we thought it was an exophytic, but it wasn't an extra lesion. It was an exophytic component of the diffuse midline glioma. Go ahead. So in our experience, all the patients had a H3, K27 altered, IDH negative. 6 cases we had TP53, ATRX, growth factor expression in synaptopsin expression. Ki67 expression ranged from 5 to 50% with a median of 20% of the cases. Additional markers, but it was really varied. It didn't bring us any information so far. And we had 2 cases with the BRAF fusion, in which one of the cases is that that kid that I did, I thought it was a extra lesion, and it came out to be a BRAF fusion. She already gone into radiation, and now she's doing great. And now, because of the BRAF fusion, we started to do trametinib and see what it comes out. She just started about 2 months ago with the drug, according to the BRAF fusion that we study after doing a molecular study of the tumor. Go ahead. So in our case study with 8 patients, what we noticed is the Ki67. It was related to overall survival. The higher the Ki67, the lower the overall survival. And again, we can only talk about this because we did molecular study with a safe procedure in these kids, and maybe giving a chance to optimize survival and quality of life. Go ahead. So this is Santa Marcelina. Tuca is the non-profit organization that actually help us providing out the equipment that we need in OR. We have a multidisciplinary team, is really teamwork. We have physiotherapist, we have endocrinologist, we have all the medical specialties to take care of these kids. We have monthly meeting with Dr. Roger Parker, the Children's National, and then recently we started to have monthly meeting with Dr. VJ from the Hospital for Sick Children. So both of them are actually helping us try to do our best here in Brazil, guiding us with the right molecular study to what to look for in those kids and when to do it. And each case is really well discussed before we do the biopsy, trying always to do a multidisciplinary decision around the kid. We have our lab, we have our molecular biology lab, and it's just that we don't have the results at all, but for all these kids, we are doing liquid biopsy for all the brainstem lesions, the biopsy we've been doing. And we have in the OR, although it's a public-private hospital, sometimes it's really tough to have surgery, high quality surgery, thinking about the monitoring and the equipment. But here we do have this available, thanks to Tuca and the oncology department that is always thinking ahead of us with Dr. Sidney. Go ahead. So for the diffuse midline glioma biopsy, it is safe. It's a minimally invasive technique. There is a diagnostic accuracy over 95%. And it is important this because we know the diffuse midline gliomas are a heterogeneous lesion. And it's really tough to treat because we don't know the response. The more we know about the molecular studies, maybe this can help us to give the best treatment for this kid with target therapy and maximize and optimize overall survival of this kids, that we know that despite of all the treatment today that we have, which is radiation, overall survival is less than a year. And that's what I wanted to share with you, and I'm open for questions. Thanks again.
Thank you very much, Roberta. It's an outstanding job you are doing in Santa Marcelina. See, the majority of the patient, I don't know how, almost his totality from the public hospital. See how beautiful is the work. Let me ask you something about the. Para de compartilhar aí, Guilherme. Let me ask you something about the high flow, the ultrasound, the high flow, you see? High intensity focus ultrasound. I think 5 or 6 years ago, when they start this technology, and they use for tremor, for dystonia, for some disease, maybe Parkinson, they say that the future will be the open or break the blood barrel, and the drug will be delivered to the tumor. But still have trial and trial and trial. Any trial has any conclusion. What you show us is a case control or is in the rat? I didn't understand.
This was in rats, using doxorubicin. And it showed it using the high intensity ultrasound with microbubbles, because microbubbles actually can, in a way, stimulate to open the brain barrier, opens the cell, and then you infuse drugs. In doxorubicin into rats showed that there was a high concentration of drugs in the brainstem, because it's one of the most hard place to get drug in the central nervous system is the brainstem. And that's what this work shows. So today there isn't anything on humans yet, but there is some, and what they're trying to do is trying to replicate this as soon as it's safe enough to doing to humans. What the Children's National is doing is using low intensity ultrasound, and that is in phase 1 and phase 2 in pediatric patients. But what it does, it uses also ALA, the ALA, and it changed the port of porphyrin using the sonic dynamic. I don't know what the mechanism is, but what it used.
What the 5-ALA will do it?
Yeah, using 5-ALA, using the low intensity ultrasound. I don't know what the mechanism is. I can ask Dr. Roger Parker because he's the one that is conducting that study at Children's National. What it has shown that it induces apoptosis into cells using low intensity ultrasound and ALA.
Very interesting. Because the 5-ALA, you see just with the microscope, no? How
Right.
You can see the 5-ALA?
Because it is, because what they use...
As a marker?
As a marker.
Como marcador?
Como marcador. Because o ALA, ele é captado, it is captured by glioma cells. And then he used the focus ultrasound, low intensity focus ultrasound. And I don't know what the mechanism is, but what I understand with the low intensity ultrasound, it changes the protoporphyrin in the glioma cells and induces apoptosis. And that's why would be a marker to drug delivered therapy. But it's still in phase 1, phase 2. But it started to do in children.
Very interesting, very interesting. Paulo, want to ask something to her? You see here.
Thank you so much, Roberta.
Byron, Dr. Arnaldo Arruda, Juan Luis Gomes Amador. Want to make some question? Go ahead, please.
Yeah, I have a question. So, do you think that the BRAF, the ones that have this mutation, they might have a better prognosis than the others?
It might. We have this, again, we have one, this kid, she is just trying to do something for it. It's a BRAF fusion. There is this drug. She's already done radiation. We did an MRI control, and there's still tumor in progress. Since there was a BRAF fusion, we start to do the drug and see how it goes. On the other hand, we have a BRAF fusion on a patient with a high-grade hemispheric glioma, and he is now on the 3rd year post-operative and post-treatment, and he's doing well. And that's based on the BRAF fusion and the drug that we introduced. He was in a clinical trial in the US, and we were actually receiving the drug here in Brazil. But he's doing a good job. He did all the protocol with the radiation, chemotherapy with temozolomide. And then we did a BRAF study, it was a BRAF fusion, and we started to do immunotherapy, which showed some good result. Now he's in his 3rd year post-treatment, and he's doing really well. So it's definitely something in the future that we can looking at for treatment.
And then when you go and study these markers, you have to do each one of them separately, or you have to do all of them separate. So actually you choose, you're not like trying to find any different marker or something like that, right?
No, we actually we discussed with Dr. Roger Parker and Dr. Vijay, and we take on basis the PNOC. Now we have the PNOC study, which is our baseline to look for the molecular markers that can actually guide us to treatment. And that's what we've been doing. Right now, we're looking for those markers in BRAF to guide us with the possible. For example, some of the BRAF that we did was BRAF mutated, and there is no drug for that. But for BRAF fusion, we do have something that we can give. We don't know in the follow-up how we turn out to be, but we have 2 patients with the BRAF fusion. One passed away, so we couldn't do it, but this other kid, we've just started 2 months ago, and let's see how that goes.
How expensive is that?
But the BRAF is not low grade.
Hmm?
The BRAF positive is not low grade.
It can be, but we try to study BRAF in all the cases because there is some drug that it can, so we're doing in all cases BRAF. In this kid, it was BRAF fusion, so we started to do it. It doesn't matter, Dr. Borba, because in that if it is benign or not, the location is bad for itself, so it's considered high grade despite of the BRAF. But if we have a BRAF fusion, we do have a drug that we can try and see how that turns out. Again, it's everything is so new. We just started to do it with the PNOC study, which was published last year. There's still so much to study about this, and we just started here in Santa Marcelina. We'll see, but it is a promise. It is a promise that if there is a molecular expression, that there is a drug that might respond treatment. That's what we're trying to do here.
And Byron, want to ask something?
Yes, thank you so much, Professor Borba. Thank you so much, Professor Roberta. Excellent lecture. I was wondering, I saw that in some cases, the approach was because the open approach, you saw an exophytic portion of the tumor. So what about when you don't have any exophytic portion? Would you do still an approach? What would you take into account to program your skull-based approach to the lesion? And I guess what happens to the whole Latin America when we see this kind of tumors, the oncologist always and he knows that maybe some biopsy is not required and just wanted to go ahead with a adjustment treatment. So what kind of consideration would you have to change this?
Thank you so much for your question. Well, that's what happens here in Brazil too. Most of the cases that you do when you see a pontine glioma, a classic pontine glioma, you're authorized to do radiation and you don't having to do anything else. And actually for the pontine gliomas especially, you're authorized to do a biopsy only if you are enrolled in clinical studies, because otherwise, what's the reason to do it? If you don't have a lab that you can do a molecular study, what the information you're going to have? You're going to have it's a glioma, pontine glioma, and you're not going to do anything. So the only reason to do something, if you're going to study molecular study, if you're going to do molecular study, and you might have something to do to add more to this kit. So here, what we do a frameless neuronavigated biopsy for the pontine gliomas. We usually take the most posterior location of the lesion, and we do a needle biopsy using neuronavigation frameless most of the cases. The only 2 cases that we did an open biopsy was the first case, there was an exophytic portion and we didn't have the navigation system. So that was the only reason why we did. Maybe if we didn't have the navigation system, there was no reason to do anything like this, because it's too risky for the patient. And the second patient that we did was because we discussed thoroughly with the radiologist, and we thought it was actually an extra axial lesion, but it wasn't. It was an enormous exophytic portion of the pontine glioma that it caught us on surprise. But what we do a safe biopsy using neuronavigation system, particularly VarioGuide. It's a frameless neuronavigation system biopsy, it is safe to do it. But again, we only do it because we do molecular studies. If we didn't do any molecular studies, there is no reason to do this because there's still the risk of the procedure.
Thank you. Thank you so much.
Viu que o doutor Montanaro aqui, ele ligou a câmera? E aí, Montanaro, beleza aí? Quer fazer alguma pergunta para a Roberta, hein? Teu microfone está desligado. Vamos falar em português aqui, ficar melhor, né, tio?
Muito boa aula da Roberta, eu vim ouvindo no carro, que eu vim vindo para o plantão, então eu vim ouvindo, gostei muito da aula, mas assim, não tenho nenhuma pergunta para ela. Não.
Obrigado, obrigado. Eu estou em dúvida ainda. O que muda o prognóstico desses pacientes hoje fazer uma biópsia nisso aí? A maioria dos pacientes, e a maioria no Brasil, na maioria dos países da América Latina, a gente não tem esse acesso ao estudo da biologia molecular nesse sentido. Desses pacientes que foram feitos a biópsia, qual realmente teve alguma coisa que tu encontrou que mudou o prognóstico?
Essa do BRAF, a fusão do BRAF, essa que tinha um componente exofítico grande. Porque assim, doutor Borba, ela é algo a mais que está sendo feito.
Mas esse era um baixo grau.
Não,
localizado.
Não, é glioma difuso de ponte.
Glioma difuso.
Depois eu vou encaminhar o vídeo para o senhor, mas assim, quando eu vi a imagem, me parecia ser uma lesão extraaxial saindo do forame jugular. Uma lesão, pegava toda a parte anterior do tronco, toda a parte. Me parecia realmente uma lesão extraaxial. Eu discuti com o pessoal da neuroradiologia. Nós fizemos a cirurgia, essa criança ela foi entubada, ela teve um rebaixamento do nível de consciência, 3 dias antes foi entubada, nós operamos, ressecamos toda aquele porção exofítico e a criança saiu. Na ressonância de controle, mostrou uma alteração na ponte. Até então não tinha saído, aí saiu o resultado da imunistoquímica, que veio como glioma difuso de ponte, um glioma de alto grau. Nós pedimos a revisão e veio, e daí na ressonância de controle mostrou. Então, assim, de novo, doutor, ela já fez radioterapia, a lesão agora já passou 3 meses da rádio, a lesão parece que está em progressão, só que a criança está muito bem. E veio essa fusão. Então, é uma tentativa de fazer algo, entendeu? Essa criança já está indo para 10 meses de sobrevida, é algo a mais. Se vai dar um resultado, a gente ainda não sabe, mas ainda é uma molécula que responde ao tramatinib. É algo que a gente está tentando lançar a mão para ser feito. Isso que o senhor falou assim, agora eu vou tentar puxar a sardinha para o nosso lado. No Santa Marcelina, que aqui a gente está sempre inovando nesse sentido de estudo molecular. Nós temos o protocolo do meduloblastoma. Santa Marcelina, ele recebe da América Latina toda, e quem quiser do Brasil, de qualquer centro, para estudo molecular de meduloblastoma. E o próximo passo é a gente tentar captar todos esses pacientes com lesões de tronco para poder também fazer estudo molecular. Né? A gente só não tem isso bem definido, como está bem definido o meduloblastoma para o Brasil todo, para toda a América Latina. Então, nós recebemos amostras da Argentina, amostras do Chile, amostras do Paraguai, nós já recebemos. Então, assim, e fora de vários cantos do Brasil. E não tem custo para ninguém, não tem custo para ninguém. É um processo que a gente está fazendo, e a ideia agora é fazer isso com os tumores de tronco, para, de alguma forma, poder descobrir algo a mais e tentar fornecer uma terapia mais direcionada a aumentar a sobrevida. Até agora a gente não tem essa resposta, porque nada foi feito até agora, ou está muito no princípio, entendeu?
Excelente. Márcio, o Márcio queria fazer uma pergunta aqui, acho que ele perguntou aqui. Liga a câmera aí, Márcio. Tá só a foto dele aqui. Tá no escuro aí, pô.
Eu tô com o Ale tá dormindo aqui. Tudo bem? Boa noite, boa noite. Obrigado, doutor Bob. Parabéns, Roberta. Eu gostei muito da sua apresentação. E eu queria te fazer uma pergunta mais por uma curiosidade minha, que eu não entendo muito desse assunto. Essa questão da biópsia líquida que você mencionou, você faz sangue, líquor, e você pesquisa alguma coisa específica ou só célula tumoral circulante?
Não, a gente faz para... Boa noite, Márcio. Antes de tudo, obrigada pela pergunta. A gente está fazendo biópsia líquida para todos os tumores do sistema nervoso central, né? Principalmente fossa posterior, nós fazemos amostra líquida, a gente usa de líquor, análise licórica. E nesse momento nós estamos pesquisando BRAF em todas amostras de biópsia líquida. Só que nós estamos fazendo esse banco de dados para poder eventualmente procurar algumas outras coisas. Uma das coisas que a gente vai discutir com o Dr. Roger Parker numa próxima reunião, ele faz a pesquisa da estona como controle do tratamento dos tumores de linha média, dos gliomas de linha média. Então, ele faz o tratamento e depois, no acompanhamento, para ver se houve recidiva, recaída da lesão, progressão da lesão, ele faz análise da estona no líquor. Isso nós não estamos fazendo aqui, é algo que a gente vai estar discutindo com ele, mas ele já publicou e já mostrou que a presença de estona no líquor, antes mesmo de alteração radiológica, significa progressão das lesões de tronco, pós-tratamento.
Entendi. Obrigado, Roberto.
Juan Luis.
Yes, sir. Good night, everyone. And the first time, I would like to congratulate Professor Roberta Rehder. I think it was a very nice and very comprehensive lecture. And I'm very glad that the work that you are doing is based on the clinical status of the patient, the molecular biology, and the surgical approach. I was just thinking about in a specific field for endoscopic endonasal neurosurgery. Do you think there is a place for these patients to have a procedure like that in order to take the biopsy?
I'm sorry, could you repeat the question? I'm sorry.
For those patients...
Cirurgia endonasal, em vez de ir pelo assoalho do quarto ventrículo, ir por via endonasal direto na porção anterior.
Yes.
Yeah.
No, that's something that we don't think about it, because we try to be less invasive as possible. So if we
children.
Children. In less invasive, with the needle biopsy, is much easier if you do posteriorly. It is much safer than to do intranasal. It's much more invasive, and that's something that we don't even consider doing, because of the invasiveness of the procedure. We try to do it less invasive as possible.
Okay, thank you.
And let me ask you something. Now you get brainstem tumor, and to refer the patient for you to do the treatment, you need to go to do the biopsy there, or can be the biopsy here and send just the sample. How you can do that?
We do the biopsy here.
The whole treatment has to be there.
Yeah, patients have to be
and
here.
Totally free.
Free. Even we have some kids from Santa Catarina. We do that. I don't know in English what it's called, but it's the DFT. It's the government.
Fala português, vamos português.
É o DFT. Na verdade, eles entram em contato, eles dão toda a orientação para o paciente, toda a orientação para ir pela via estadual e ser transferido para cá sem custo para o paciente. O Estado acaba pagando tudo, até esse transporte. Nós já conseguimos 3 pacientes de Santa Catarina que veio para cá encaminhado para nós. Pro meduloblastoma, Dr. Borba, esse não, esse é feita a cirurgia no local. Então, vamos supor o senhor tem um caso de meduloblastoma, o senhor opera o meduloblastoma, o senhor quer conhecer todo o estudo molecular dele, tem todo um protocolo que a gente orienta, o senhor envia, até o envio das lâminas, tudo, isso fica tudo por conta do protocolo que a gente introduziu. Então, e daí fica mais fácil até para o senhor saber qual que é o subtipo molecular que o senhor está tratando, né? Então, é uma forma que o Dr. Sidney idealizou para a gente saber qual que é o mais frequente subtipo molecular, né? Até para orientar o tratamento. E a gente manda as lâminas, a gente pede as lâminas por um motivo, porque a taxa de erro de patologista no estudo de lâmina é muito alto.
No
A
mundo
taxa
todo.
chega em torno de 30%. Então, por isso que a gente solicita que as lâminas venham as lâminas para fazer uma revisão do caso e daí sim fazer o estudo molecular. Então, para meduloblastoma, não. Meduloblastoma, quem tiver caso no Brasil, na América Latina, quiser entrar em contato conosco, a gente faz todo o estudo molecular dessa criança e ela fica sendo tratada no local de origem. Mas para os tumores de tronco, por conta de ainda ser algo que a gente está iniciando, a gente também quer, de certa forma, assumir esse paciente, né? Acontece qualquer coisa, dá um erro lá, pode falar que foi por conta do erro de biópsia, de erro de... Então, a gente assume esse paciente e faz todo o tratamento por aqui.
Mas não vai custar 300 mil reais, como tinha uma vaquinha esses dias aqui de um paciente de Santa Catarina, né?
Não, doutora, aqui não tem vaquinha.
300 pau era uma vaquinha, Paulo Cadre. Dá para pagar 2 implantes do teu aí. Pô, fantástico, fantástico. Não sei se tem mais alguém aqui que quer fazer alguma pergunta para a Roberta. Eu acho essa oportunidade de poder encaminhar esses pacientes para fazer esse estudo molecular, principalmente no meduloblastoma, é fundamental, porque se sabe hoje que o estudo molecular muda completamente o prognóstico do paciente. O estudo molecular mostrou a diferença, 1, 2, 3, 4, precisamente o 4, parece que tem melhor prognóstico, né? Isso muda de forma substancial. No meduloblastoma tem alguma faixa etária ou aqueles pacientes adolescentes, às vezes, que ele vai um pouquinho mais lateralizados, desmoplásicos, vocês também aceitam, ou só aqueles de linha média, uma faixa etária menor?
Como assim? Como assim, doutor?
Os meduloblastomas de uma maneira geral,
Ah,
independente da idade, independente da...
Independente de tudo, doutor. Independente. Se o senhor tratou o meduloblastoma aí, fez, é só o senhor entrar em contato com a gente, depois eu deixo o meu e-mail aqui, entre em contato, a equipe nossa já passa toda a orientação que precisa, porque precisa também, tem aquele consentimento para não ter, então
Isso.
precisa assinar termo de consentimento, até porque está manipulando a amostra de paciente. Mas a ideia é essa, nós fornecer o estudo molecular para saber qual que é o subtipo molecular para direcionar tratamento. Então, não importa
Excelente.
a idade, não importa não importa. Fez um caso de meduloblastoma, encaminha para nós, a gente faz o estudo molecular para direcionar o tratamento no local, na cidade local.
Byron, in Ecuador, you can do that. You can get the molecular study for the patient from the public hospital or not?
Não, não, a gente não faz isso não, professor. A gente
Não?
poderia tentar procurar os pacientes os hospitais pediátricos, que eles têm mais volume, né, de criança, e tentar ver se a gente pode fazer algum convênio, né, para enviar a amostra, ou o paciente, né, principalmente porque a passagem é cara, né? Aí acho que tem um limitante, né? Mas se tem como fazer esse estudo lá, levar o paciente lá, a gente pode fazer, né? Pode tentar falar com o ministério, né?
Lá. Juan Luis, em México,
Yes,
¿se
only
hace
for
el estudio molecular para la paciente del hospital público o no? ¿En
yes.
el instituto usted consigue hacer?
At the National Institute, yes, but this is for adults only. But for pediatric patients at the National Institute of Pediatrics, they perform the molecular studies, but in the estatal public hospitals, it's difficult to get the study. Yeah. For public
Excellent.
hospitals, yes.
Maybe you can get the whole Latin America, Robertinha. Vai ficar famosa.
No, really, we know send us to us. We're doing a really nice. We actually send this project to the Congress of Neurological Surgeons, and we won the prize for this project. That was last year. And for this project for medulloblastoma, because we're doing all Latin Americans. It's just that it's not everybody knows about it. We try to do nós tentamos fazer isso via SBN já há algum tempo, mas assim, não progrediu a ideia, doutor. Mas tem muitos lugares do Brasil que ainda mandam para nós. Poderia até ser muito mais, mas da América Latina a gente está conseguindo aos poucos cada vez mais amostras.
É importante isso. O custo é fundamental para um país pobre como o nosso, e a América Latina inteira, o custo é fundamental. Porque às vezes se utilizam disso para ter outras... Criança é diferente, né? A pessoa sente muito no coração isso. E às vezes as pessoas vendem uma realidade que não é a realidade da coisa. Não sei se tem mais alguém fazer alguma pergunta para a Robertinha aqui. Doutora Robertinha é brava, né? Doutora Roberta. Ok. Thank you very much, Roberta. Montanaro está de plantão? É segunda-feira à noite?
Professor, no chat tem uma pergunta aí, no chat.
Mas é do Márcio? Ah, não, tem da
Não, tem uma
Júlia.
outra. Entrou uma outra pergunta aí.
As amostras precisam de algum preparo diferente, alguma coisa específica? E se vocês mandam o protocolo todo direitinho, como é que prepara?
Mando o protocolo. Eu gostaria de saber como que eu posso deixar meu e-mail, doutor Borba?
Isso, pode deixar.
Como que eu posso deixar? Eu coloco aqui no chat?
Coloca aqui no chat e depois nós vamos fazer nós podemos fazer tipo um flyerzinho e a gente distribui isso aí na América Latina inteira.
Não, porque nós temos muito interesse.
Como que manda, como é que recebe, o tipo de patologia, como é que tu quer os dados dos pacientes, eu sempre ter os dados completos, a gente consegue. Vamos fazer tipo um protocolo assim de que tu precisa, os dados que precisam e como que faz a referência, a gente consegue. Vamos envolver bastante gente, isso é um troço bacana.
Se ainda tiver oportunidade, eu posso pedir até para o Dr. Sidney fazer uma apresentação do trabalho dele, porque assim, ele que está liderando tudo isso, ele é um oncologista.
Isso aí nós podemos conversar, vamos conversar depois em off, a gente organiza tudo isso aí.
Isso, mas é interessante
tudo isso aí, muito bacana.
para as crianças como um todo, né?
Show.
Doutor, obrigada, doutor.
E a Luísa?
Luísa está bem. 4 meses, tá bem, graças a Deus.
Já voltou a trabalhar ou não?
Não, doutor. Pedi para voltar antes. Vamos ver se o Santa Marcelina vai me autorizar. Falaram que é o primeiro caso que pede para voltar antes do tempo. Vamos ver se eles vão autorizar.
Beleza, então.
Obrigada, doutor.
Obrigado, um abraço a todos. Obrigado. Tchau, boa noite.
Tchau, boa noite.
Bonito.
Boa noite.
Saludo. Mário, hablamos más tarde.
Profesor, listo.
Okay.
Nos vemos.
Listo. Chao.
Tchau.
Chao.